Hello and welcome to the topic Ventricular Septal Defect in the Cardiology module. By the end of this topic, you should be able to define ventricular septal defect, describe the pathophysiology of ventricular septal defect, outline the classification of ventricular septal defect, identify the signs and symptoms of ventricular septal defect, describe the investigations done to diagnose and prognosticate ventricular septal defect, and outline the principles of management for ventricular septal defect. Let's get started. Ventricular septal defect is a congenital cardiac malformation in which there is a hole or pathway between the ventricular chambers. VSD is a type of left to right shunt that results in an increase in pulmonary arterial blood flow. Owing to the distensibility of the pulmonary artery, large volumes of blood can flow without an increase in pressure. Thus, large left to right shunts can exist without an increase in pressure. The increased flow through the pulmonary valve gives rise to murmurs and predisposes the child to frequent chest infections due to the engorged pulmonary vasculature. During ventricular contraction or systole, some of the blood from the left ventricle leaks into the right ventricle, passing through the lungs and re-enters the left ventricle via the pulmonary veins and left atrium. This has two net effects. First, the circuitous refluxing of blood causes volume overload on the left ventricle. Second, because the left ventricle normally has a much higher systolic pressure than the right ventricle, the leakage of blood into the right ventricle therefore increases right ventricular pressure and volume, causing pulmonary hypertension and its associated symptoms. In serious cases, the pulmonary arterial pressure can reach levels that equal the systemic pressure. This reverses the left to right shunt so that blood then flows from the right ventricle into the left ventricle, resulting in cyanosis as blood is bypassing the lungs for oxygenation. Various classifications are used, however, the most unified classification is that of Congenital Heart Surgery Nomenclature and Database Project. This classification is based on the location of the VSD. Type 1, which is subaortic type. Subaortic VSDs occur just beneath the aortic valve at the left ventricular outflow tract. A venturi effect can occur from the left to right shunt, causing the aortic valve leaflet to prolapse into the VSD, resulting in significant aortic valve regurgitation. Type 2 is also known as perimembranous, paramembranous, conoventricular, membranous, and subaortic. This type is the most common variety found in 70% of the time. Type 3 is known as inlet or AV canal type. However, is commonly associated with atrioventricular septal defect found in about 5% of cases. Type 4, also known as musculotype, located in the muscular septum, found in 20% and can be subclassified again based on the location into anterior, apical, posterior, and mid. And the final type is the Gerbaut defect, which is also known as left ventricular to right atrial communication, and this occurs due to the absence of atrioventricular septum. Let's now move on to making a diagnosis of ventricular septal defect. It begins with recognizing the symptoms. VSD manifests itself at around 6 to 10 weeks of age in the form of congestive cardiac failure. Palpitation, dyspnea on exertion, and frequent respiratory infection also may occur. Signs which are appreciated on examination include hyperkinetic precordium with a systolic thrill and a loud pansystolic murmur. Echocardiogram is used to identify any defects within the heart chambers and to assess the overall function of the heart. Cardiac catheterization provides information on the pressure gradient between chambers and vessels and is also used to evaluate cardiac shunts. Eisenmenger's syndrome describes the reversal of a left to right shunt in a congenital heart defect due to pulmonary hypertension. This occurs when an uncorrected left to right shunt leads to remodeling of the pulmonary microvasculature, eventually causing obstruction to pulmonary blood flow and pulmonary hypertension. In this case, it can be associated with ventricular septal defect. Features include original murmurs having disappeared, cyanosis, clubbing, right ventricular failure, hemoptysis, or embolism. and the management here would be heart-lung transplantation if required. Now, let's start with the basics of interpretation of the oxygen saturation on cardiac catheterization. So, deoxygenated blood returns to the right side of the heart via the superior vena cava and inferior vena cava. It has an oxygen saturation level of around 70%. The right atrium, right ventricle, and pulmonary artery normally has oxygen saturation levels of around 70%, and the lung oxygenates the blood to a level around 98 to 100%. The left atrium, left ventricle, and aorta should all therefore have oxygen saturation levels of 98 to 100%. The oxygenated blood in the left ventricle mixes with the deoxygenated blood in the right ventricle, resulting in intermediate levels of oxygenation from the RV onwards. The RA blood remains deoxygenated. The management of ventricular septal defect can be seen from the perspective of medical and surgical basis. Medical management in the treatment of ventricular septal defect is aimed at managing congestive cardiac failure, treating recurrent chest infections, adequate transfusion of blood products for anemia, and treatment of infective endocarditis if present. Surgery is done if large left to right shunt, heart failure occurs in infancy, and associated pulmonary stenosis. It can be closed with a patch as early as a few months after birth. For muscular defects in older children, catheter closure can be done. To summarize, ventricular septal defect is a congenital malformation where there is a pathway between the ventricular chambers leading to oxygenated blood in the left ventricle mixing with deoxygenated blood in the right ventricle. The perimembranous type is the commonest type. This eventually leads to pulmonary hypertension and, if left untreated, can cause Eisenmenger syndrome, which is the reversal of shunt. Heart failure symptoms can be managed medically. Closure of the defect is done if it is large and causing worsening symptoms. So we have come to the end of this topic. Thank you.